interrupting. So thank you, Rachel. And if I hand over to you, and I look forward to hearing what you've got to say.
Okay.
Thank you.
Well, it's great to meet you all in the virtual room, and I hope you have plenty of questions. And I hope this session will really just trigger some thoughts and put some questions into the chat box. It really is a flying tour, so put your seatbelts on, and I hope you're sitting comfortably. I'm going to split it into 3 sections. The first section will be care after death, and then the bereavement key working, and lastly self-care. Oops. I'm having problems in the slide. Can Simon help? There we go. We've gone. So the first section is care after death. And like Katrina mentioned, many of us as children nurses work in so many different environments. And therefore, I appreciate that your experience will be different. Some of us might be, for example, a children's nurse who works solely in death as the part of the CDOT process. Some of you might work in accident and emergency, so the emergency department, where you are seeing children in that sudden expected death scenario. So we'll be looking at in all the different various environments, the personal care and the changes to the body, and also the communication with the family. And in that, I put here in brackets visiting and viewing. So I'm going to pull on some of the experience, and I just want to start at the beginning to acknowledge both peers and colleagues who have taught me along the years and the decades I've been nursing, but also especially the bereaved parents and families who I worked with latterly in the last decade.
I'm just on the road to my sister's and I was suddenly thinking I must email Caitlin.
Hello.
Just let her know of our final number.
Sorry.
Can you go on to mute, please? Thank you.
So looking at the practicalities and changes, and I always think as children nurses, we're not really taught this when we're learning about death and dying, but the different type of mortis. And I think it's quite important because especially in the acute setting where the child has died, rigor mortis is when they go quite stiff. But I never knew until latterly, until working with deceased children, that disappears after 36 to 48 hours. And so therefore, knowing these sort of things, you can reassure families. And so the livor mortis is very much, like when you get the bruising, it's where the red blood cells sink and it gives that bruising effect. And that can be quite distressing to the families. So I often say we haven't knocked or it's not bruising, but just explain what it is. I think careful and explanation really supports the families at that time. And normally that sort of will disperse, but also on embalming, if families choose to embalm their children, that will go away as well. That's when they exchange the blood for a preservative chemical. Alga mortis is the change in temperature. And I think this is some dilemma sometimes when children die on the units and on the wards, is how long do we keep them in the rooms before we take them down to the mortuary? How long do we, for example, if they die in the community in a palliative care setting, do we put them on a cold mattress or cuddle cots? I think this is open for debate, and I'd love to see when we start talking about this in the chat box, is to think about what are the family actually seeing when they want to visit their child and see their child. And often it's the face. And so when we're thinking about the changes in temperature, both funeral directors and mortuary teams will push us as nurses to get them in the refrigeration quicker, because this is purely for around preservation of the body to the best it can be, to enable viewings. But my experience has been over the years, once parents start to see the deterioration in the body, that helps them come to understanding that the child has died and it's part of the process. And careful explanation when they're doing we'll talk a little bit more about visiting versus viewings, the terminology that we use with families. But it's important just to say the changes that families might experience. I've put a slide here that you can look. It's a bit gruesome, but it is, that explaining of the corneal changes for parents when they see, Rachel, the eyes are slightly open. Working with funeral directors and mortuary teams, they can use a little bit of tissue under the eyelid to help close the eyes. And I think those little techniques that our mortuary teams and our funeral directors have will support us when we're supporting the families. But it is scary for families. I think TV and what we see on CSI doesn't help us, which it dramatises death, and it's just the fear factor. So I think sometimes when we get chance to do simulation around when a child dies, is really important that we learn all these things that in our toolbox. So I often think today I'll be talking about things that you can add to your toolbox. You might already have them in your nursing toolbox. Lastly, we talked about the changes in the body, and another thing I just wanted to touch upon actually before we go on to this next slide is the body and the positioning of the body, thinking about the rigor mortis and when the children, we had one case, remember, once the nurses weren't aware of rigor mortis and put a deceased child in a car seat, thinking, oh yes, we've got them secure. And the parents phoned me to say, Rach, we've got home and rigor mortis had set in. And so it was really difficult. We had to get the funeral directors to get the child out of the car seat. And it did eventually, the child did flatten and become straight. So it's just to be mindful of these when we're transporting children and thinking about the impact upon the family. And as at the moment, when you look at these lists of normal grief reactions that families had, I'm sure if for those who have taken driving tests or exams, we will have quite a lot of these reactions. But if you can magnify and think of this 100% more, the intensity of these feelings, for example. It's not a tick box. They're not going to experience all these all in one go. This is just to give you some idea of collective. This is no mean least exhaustion of a list of feelings that they would go through. One of the things I just want to pick out here is the physical sensation. And often families will tell you, especially if it's baby death, that they have aching limbs, their arms feel really heavy, especially if they've been holding the child as well. And visiting the grave is one thing on behaviours. Society gets very hung up with, do we memorialise the children and how we do that after they died? And community visiting, when you go to visit and they've got, for example, a death mask. Families have had death masks done and put lights around that. That was important for them. It is no right or wrong way to grieve. And I think this is really important. You'll appreciate, I'm sure, on different cultural behaviours as well, of beating of the chest, collapsing to the floor. All these things, it's just be mindful of. It's not because there's anything medically wrong or we need to call upon the psychiatrist. It really is to give families sacred space and space to grieve. I think it's when it's really hard is when you're on a hospital unit and there is screaming and shouting, and we have to obviously take care of other families. So how we manage that, I think obviously when you're being truthful and transparent with families and being mindful, and just explain that there are other children on the ward and give them a place to go and do that. That's quite a good handy hint that we've used before. So give them safe places to be. So a lot of this is, you'll find that often at the time of death, one parent or somebody in the family will take instruction really well. But I think I have to be, my advice would be, it's always small little bits of information. So as nurses, we generally are in the fast lane, aren't we? We never normally just have one patient to look after. We might have 4 or 5 children to be looking after on that duty. So we are then in the fast lane of busyness of life. We have things going on that we bring into the workplace. So it's being mindful as a children's nurse is just to slow down and being present. One of the key things that families feed back to me, bereaved parents, is they remember the nurse that was present with them at the time of death, that wasn't busy fixing the bed linen, that running to the linen cupboard or running out of the cubicle, but somebody who could stand within that room and acknowledge the pain and the sadness. And I think that is really a gift that you can give to a bereaved parent, is actually being present with them at such a distressing time. This next slide is, I just wanted to touch upon the grief. And I often call it the two eggs. It's called the dual therapy by Strobe and Schutz. I call it the two eggs because the loss orientated is the grief work and the restoration orientated is the distraction. And what you want families to do is to be able to oscillate between the two eggs. You want them to be distracted and you want them to be able to do the grief work. As and when and to what timings they do that, there's no rule to that. What we will find, however, if one family sits, if a person sits within the loss orientated and doesn't work through their grief work, there will be mental health and issues along the way, and they find it hard to distract. And the same again for families who constantly distract and don't want to deal with the grief work. So what you're ideally looking for is, sometimes you might be busy cleaning it if you're a community nurse, they're doing the house cleaning, and you think, oh, I didn't really realise that the child has died, or they've taken it on, and you're worried. But actually, there will be a point when they stop and talking to you. They will do their grief work. But it is, sometimes it's private and they all do it in different ways. I think what's really important is to reassure families of grief and having that little knowledge within your toolbox that it's okay that somebody might cry, somebody might not. There's no tick box. A lot of people used to refer to Kubler-Ross and going through phases and stages. It isn't like that. Grief will hit you at all angles at different times. And so it's that gift that as a children's nurse, we can be very much present with them. I put this slide in because I felt it was really helpful. I remember when I was nursing, I used to get really tongue-tied, and when I worked at the children's hospital, I was thinking, have I got the right language to talk to bereaved families? What do I say? And I think, oh, let's wheel in a psychologist because they have the right language to use. And some real things I've learned along the way. So you'll see this pyramid, and it's a phenomenal resource to look at when you're setting up criteria for grief and following on work. But all of us are on level 1. And what's really we see in the purple section is needs. What are the needs for the family? And you can see here it's explanation and reassurance. Occasionally, acknowledging that list I've been through, saying that it's okay, normalizing this is what grief is. Because it can be really frightening. A lot of people have never had that intense feelings and emotions before. And getting them to be curious and to ask questions is really important. The information and guidance. And this is really the services support that they will require. And I'm going to talk a little bit more about the bereavement key worker in the next section. But this is very much what a bereavement key worker will do after the child has died. And an awareness that grief is normal reaction to loss. So those 4 sections that were looked at, just normalizing that visiting of going to the grave every day is okay if they need to do that. It is understanding the backgrounds, and sometimes we are fortunate to have that relationship, aren't we, with these families, especially in haematology and oncology or long-term conditions. And we build that relationship with the family. So at the time of death, there's our own grief as well, which I'll talk about at the end when we come to self-care. But all these things are really important to understand. When we refer, not everybody needs counselling. And so levels 2 and level 3 are very much talking therapies and counselling. Level 4 is very much where we refer on to psychotherapy, where they might have suicide ideation, the self-harming, and they're needing a specialist service, mental health service. So that's when we would refer on. In the NICE guidance within the UK, within England and Wales, we have the 3 levels. So 3 levels.
Have you got stuff you could have?
Sorry, Rachel.
It's okay.
Oh, okay.
Okay, so the 3 levels are really important in that we have that universal level, and level 2 and level 3 are incorporated in the NICE guidance for psychological support.
Simon, can you take Rachel off mute, please? Rachel, it might work if you try.
Okay, it's worked. Sorry, guys. Thank you all for being so patient. So looking at the bereavement key working, when we were designing this sort of role and this, when we were looking at the child death review, setting up the guidelines in 2018, it was my role as clinical nurse specialist in HIV days when I worked there that we would have done the bereavement key worker role. That was very much a natural part of following up with the families. However, we realise that since we've launched this role, it's quite been a burden on quite a lot of people's roles within children's nursing. So I'm going to touch upon the aspects and the difference between the expected and the unexpected death, especially for those in emergency departments. You're going to see quite a lot of SUDICs that come through the sudden unexpected deaths, and signposting and resources. And looking at the child death review process, I think it's worth mentioning for those in England and Wales, and I'm sure others might have some sort of process like this. I've put these guidelines on here for a point of reference. So a lot of the references around the child death review is the 2018 guidelines. And that the National Child Mortality Database is the next information that you can Google in 2019. And then When a Child Dies leaflet, this is given to all families in England and Wales. It's out of date at the moment. It needs to be updated since we had the medical examiner role introduced. And also the guide for bereaved families around coronial service. So when children die unexpectedly, the medical examiner is informed, and normally they'll inform also the coroner, and the police will be informed. So the child death review teams are told. And so SUDICs, there will be a joint agency response from multidisciplinary that will visit the home if a child died at home or at the hospital, and they'll go to the house as well. For example, we've had young people that have been at a party, taken ecstasy, and gone into organ failure, and they've come into our intensive care and then die. It's still seen as sudden unexpected death, and therefore forensically their hands will be bagged. That's quite distressing for nurses and for teams to see bags hand, because it's all becomes a forensic scene, and that is very distressing. So I'm going to move on to looking at the legal aspects. So who is the key worker? Often the model that we've used at our hospital, we don't have an emergency department. So a lot of the families that we see, it would be family liaison sisters on intensive cares, or the clinical nurse specialist, or the social worker. It can be anybody within the multidisciplinary team, the team around the child. I guess there's some areas. They have children death nurses that would take on this role. But the key working role is really key, is that it's supporting the families at such horrendous time for them. The main responsibilities is to be the point of contact for the family. So within our packs, we give them the contact details of who their bereavement key worker is. It might be somebody already, ideally, somebody already known to them. But like I said, those sudden unexpected deaths, sometimes it is a stranger. It's to help coordinate meetings between the family and professionals. So it's really a gatekeeper, not having all the professionals calling them all the time. So that's schools, health, social care. It's to cover all agencies. Be able to provide information on the child death review process. Again, this is England and Wales only, but understanding what it's all about. And in that when a child dies guidance that we give to families, it's all written in there. But my experience is families are so overwhelmed at the time of death, they find it really hard to do any reading. Most of it goes in the bin. And so it's important step by step, just giving them pieces of information as required. It's quite hard for families when, if it's an unexpected death, even if the child's been ill in hospital for quite a while, we're still not expecting that child to die within that 24 hours. And the medical examiner will often say, actually, we're going to refer this to coroners. And for those families from Abrahamic faiths, it's really difficult because they want to proceed with burial really quickly. And it does delay the process in this, and it's very distressing for families. So it's just that information and being able to give them step by step around the process. It is very much like what the police family liaison officers do. You know, they have a normal job as a police sergeant, for example, and they'll take on a family liaison role in just supporting the family and gathering information. They represent the voice of the parent when it comes to the child death review meeting. And this is a meeting of professionals. The team around the child gets together and they look at any modifiable factors of why the child died or any learning factors, and the parents and the voice of the questions that the parents might have, both positive feedback and questions around the child death. And also to signpost to expert bereavement support if required. When I say if required, lots of families, like I say, don't need counselling. They have their own communities around them. But I have found that, especially working in London and inner cities where families have moved around and they're away from family and away from their communities, it's really difficult, and often counselling supports them in that way too. So the medical examiner is to provide safeguards, and this only sort of started live. We've been over a year now with them, where the doctors have to agree with the medical examiner what's to be written on the death certificate. So no longer do we have the book where we just issue the death certificate. It has to be an agreement what to write on the death certificate, or whether they refer to the coroner. Now, they might refer to the coroner, and the coroner might say, issue the death certificate. I agree with this to be written on. Or they might say, actually, we need to hold an inquest, or we might need to do an autopsy. And I'm going to explain a little bit about the different autopsies in a minute. But it's important to understand that, again, it slows down the process for families when they're wanting instant results, and it's hard for them to understand this. Both the medical examiners work very much on the hours of registry offices. So that's Monday to Friday and Saturday mornings. And so there's often a delay on burial if there's any deaths on a Sunday, and Monday there's always a backlog with the coroner's office and the medical examiner's office. So I'm not talking about the fiscal proctor in Scotland, you have that, but in England and Wales is around the coronial. So basically it's the unexpected death that we refer to the coroner, or they've been in an operating theatre within the last 24 hours. That has to be reported in, and the coroner will look at that. But it's also both the medical examiner and the coroner is independent of the hospital teams or the medical teams. And again, the coroner's officer will liaise with the family around postmortems. This is some of the difficulty, and then we're seeing a change. I don't know whether anybody else can put in the chat box the changes that you're noticing within your own practice, is that families want to know where their child's gone. So paediatric pathology is really difficult. There's only a few centres that have paediatric pathologists, and therefore there's a huge backlog. I know in Northern Ireland, most of the children will come over to Liverpool for their postmortems. So again, this delays all the time. And working with the families when they want to visit their children at this time, it's normally they can visit post the autopsy and see the child. And again, that can be quite distressing. So it's walking through on that visitation of what the child looks like and an explanation. So there is a guide that I mentioned about working with bereaved people. So going on to resources now, I think it's important to know what resources are out there. And this by no means is every resource that's out there, but it's just to give you a taster. We talked a lot about the changes in the body and the nursing practices around. So this is the adult version, Care After Death. It's the 5th edition. And there's some really good practical tips in how to take care of the body. Together for Short Lives have done an excellent one on caring for the child at the end of life. And I've put in about the multi-faith as well. I think it's having that understanding, isn't it, of all cultures and rituals that need to take place. My rule of thumb is check out with the family. There's such a vast expanse when it comes to spectrum within their faith. So, for example, if we choose Christianity as a faith, there's a huge spectrum of beliefs and rituals within that. So just by reading upon Christianity doesn't always give you, it's best to ask the family what they want in the moment. I put some things about memory taking, and again, we have here in the hospital for Louis boxes, and we used to have Simba, but that's from Scotland, and they've had to reduce these. But any sort of memory box that you might have, not everybody wants a memory box. I think as nursing, we are so trained, aren't we, to fix it. And what's really hard with death is we can't fix it. We can't rescue. We do our best to make things a bit easier than in such a difficult and sad time. But one of the key things, like I said, is being present, but being aware that not everybody needs a handprint and footprint, and it is checking out, do they want those? My experience has been, and those who work in neonates, is that a lot around baby death, they do like the handprints and footprints, but I wouldn't assume that every family want that. And often there's 2 teddies of sorts in the boxes. One stays with the child and one stays with the family. And there's lots of other resources that are out there. But it's important. So books for siblings. I think We'll Meet again in Jannah is a fantastic one for our Islamic families, for children to understand about Jannah. The Muddles and Puddles, that's a real sort of from age 5 to about 8 years, 8-9 years. It's crafts and working through, enabling them to say their goodbyes. Another one, the booklets here are free. You can get from Sibling Support. My brother's died, sisters have died. And the other 2 that you see there, they have different ages. So under 6, over 7s, and one for teenagers. And that's written by bereaved siblings for bereaved siblings. But this is just to give you a taster. Again, it's not an exhausted list. Siblings, and also there's books that are out there. There's very little out there for teenagers when we're offering bereavement support. So that's why I put a Mindful of Grief. That's a good one for young adults. But there's also apps that they can go on. And there's ones that will really, I'm sure you can share in the chat box with each other. You can recommend from your experiences too. I haven't been able to put everything on the list. I just wanted you to have a taster. And these are some of the organisations that are out there within the UK. Just to say that most of you will know that the Child Bereavement UK and Winston Swish are joining together and becoming one. So they're just going through that process at the moment. I put two bereavement directories on this, the atlos.org and the Good Grief. These are bereavement directories where you can pop the postcode in and see what's locally, what's available for them, because there's different types. I do find that working with bereaved families, they like a menu of, you know, they like group therapy, individual therapy, couple counselling. So we offer here individual counselling, couple counselling, and then we signpost them to group work. But we also do the memory days, making wreaths and going for walks and memory services. So I'm sure you can share what you do within your areas. It'd be great to hear from around the UK what you do. Grief Encounters is one, and especially for baby loss, SANS and the Lullaby Trust. So there are Pacific ones that offer free counselling as well. We are finding that there's huge waiting lists for counselling now. So I've noticed since COVID, the demand on counselling is huge. So last year, for example, we went up by 25% counselling to 35% counselling increase this year. So over 600 sessions were held last year. So we are seeing that natural demand, and working with my colleagues around the country on the Bereavement Children's Hospital Network, we're seeing that too, that all our services are seeing an increase on need for counselling. These are helpful websites to know, is support. So children's funerals are funded generally within England and Wales. That does not mean they fund absolutely everything from the government. It literally is the basics. So headstones, it doesn't incorporate. And so those, if they needed horses and carriages and extra things, that they would not. It's just the basics. So it's worth going on that website, on the government website, to see what it covers, but also that there are charities out there. And Colourful Coffins give discount under the Children's Funeral Charity. So just looking at the child death overview process, I mentioned earlier about the child death review guidance and the National Child Death Mortality database. What's sad is this really started back in 2010 when we saw an increase in the UK. We had one of the largest paediatric deaths within Europe, and we wanted to know why did we have so many deaths? And so this is where we started to record through child death overview panels, and they sat under social care and social work under safeguarding model. And then in 2018, it really needed to move to the medical model because children weren't dying just because of safeguarding issues. It's very much disease progress. And we still have the largest group of deaths, age of deaths is under 2s through all our range. But we wanted to learn what are the modifiable factors within child death. And so that was the development of the National Child Mortality Database. They do free webinars, and they're really good on reports at looking at SUDI deaths, for example, deaths of swimming pools, health and safety issues, along with other types of deaths, epilepsy. So it is well worth going on as a resource interested in your area of paediatric and children's nursing. And like I said, the When a Child Dies leaflet, we work with bereaved families from different charities to write this. It was interesting writing this leaflet with them because the leaflet we proposed to them, they said it was too fluffy, too soft around the edges, and they needed it a bit more hard hitting. And that was an interesting piece of work to work with the families around developing that leaflet. So like I mentioned, the child death review happens locally. That gets fed through to the child death overview panels in the area, and they must have in the area for systemic learning at least 60 deaths a year as the footprint. And then that gets fed into and nominalised into the child death mortality, so that we can see what the deaths are and why, and what do we need to change. So the child death review meetings, this is where we glean information, team around the child. The parents are not invited to it, purely because we want the professionals to be really honest and open about if there are any modifiable factors, and just any learning that needs to raise within the team around the child. And it can be, for example, when you get to a tertiary centre like we are here at Gosh, we could have like 13 consultants. They could be under different teams, and both a local hospital and their local specialised hospital, the GP, the school. It's really important to have everybody so you get a complete picture about the child. And then the bereavement key worker will go back to the family with their questions answered, and also the opportunity for the bereaved parents to meet with the doctors and different teams that they want to meet with to ask those questions. I'm all for bereaved parents having a voice and enabling them. As children's nurses, we can enable them to be curious. I think we need to be curious as well and ask the questions. It's not a blame game. So this is how it works. The child dies, and then there's this time where the immediate decisions, making notifications, investigation gathering, and then we have the child death review meeting. And parents think this happens really immediately. The fastest that it would happen would be within 3 months. It normally takes a lot longer, and there is a backlog with areas where it's really busy. It can be a year, 18 months later, they do the child death review. And then that's fed back into the national mortality so that we can learn. So latterly now, I'm coming to talk about, and I hope we have some time for questions. That's why I've been speeding along with this session, is self-care and the emotional labour. I think as children's nurses, we need to see that we're not covered in TFAL, are we? We don't have that sort of waterproof covering that enables us to keep things that are happening personally to us and in the workplace. We don't suddenly walk through the doors at work and we're a new person, that we're just work focused. So I think it is important to just understand the cost of caring. And I'm going to explore in this next section that we have hot and cold debriefs, supervision, self-awareness, and reflect journaling. So the reason why I put this slide together is, notice it's not a picture of me doing the stretching and the warm-up, but I think if we can be prepared for this and have a self-awareness of who we are, where we are in that moment. So I might get to work and I might have had personal loss as well. And I get, when we're allocating which children we're looking after, I think it's important that we say to those in leadership, actually, I'm struggling at the moment, having that self-awareness, happy to take the case on, but I have this going on personally. I think it's not a weakness. We're not all, like I said, waterproof resistant to death and dying. And I think it's really important to be that self-aware. But we get ready for work and we're prepared, aren't we? That's why we're talking in this safe environment today about what's in our toolkit. Do we have everything in our toolkit for our work? This is me flat on the floor. That's how I feel sometimes at the end of the day, when all I hear is, I can have 6 sessions with families. It's that grief and that pain. I remember when I was working within our mortuary teams and supporting them when we have forensic cases. And I noticed that when I had been supporting family through the homicide cases, that it took a lot more out of me than when the children died from disease. And it was an interesting reflection that I had on myself. So that's when I know that when I did my children's training, we were very much taught about the reflection model, reflection in practice, or reflection in the moment or after. I'm very much the person that reflects afterwards. So journaling would help with that. So I realised that, for example, that scenario that I shared with you about working with homicide deaths, that I needed the nature nurture, looking after myself. So I remember during COVID, I used to we have a beautiful gardens here in Kew, go and just look at nature and be alone with nature. I found that really healing and a part of just resting. You know, if you're doing a marathon, you collapse at the end of it, you need recovery time. And it's like that with work. So I'm not going to talk about exercise and good diet. We all know that as nurses. We know the basics. But it's really important to just recognise, when do we need recovery and what does recovery time look like? I remember working with a phenomenal psychiatrist who, when I worked overseas, there were lots of deaths working with children dying of HIV. And I remember her saying, Rachel, you have to learn to regress. Children do that very naturally with grief. They regress. So have a PJ day where you stay in your pajamas, or eat your favourite food. Like I remember, what was comforting to me was Heinz tomato soup. It's not something I would normally have, but needing to regress and recover and recuperate, those things, it's whatever works for you, is really important to be mindful of. We all have this emotional labour, and I think it's really important to express one's capacity. I love this statement, to manage personal emotions, sense other people's emotions in the team that we're working with, and respond appropriately based on your job, especially in children's nursing. If you are able to manage your emotion and your burnout or whatever you're feeling and provide care for your patients, you need to be supported to enable that. And I think it's really important. I'm going to touch upon Schwartz rounds. I don't know whether you do it within your areas, but that's something to look into, where that's a safe place often to look at cases and explore feelings. Restorative supervision. What type of supervision do you receive as a nurse? So clinical supervision, or I receive like case supervision with the cases I see for the grief counselling that I do. But also I have a coach and a psychotherapist when looking at different elements of my role. Whoops, gone a bit too far. So looking at safety nets, I talked about supervision, and the debriefs are really important. Schwartz round. I call it lavender duvet days. I even now, if I've had a real tough week and I'm going to be off at the weekend, I will send in my group of friends a WhatsApp, just mention the word lavender, and they know not to disturb me that weekend. I need to shut down the hatches and restore myself and recover. And I think that's really important. Sometimes if we're mums and wives and whatever we are, and dads, it's just that we might be busy with other external factors as well, having an impact on us. But trying to find a safe place and just shut down is important. As a manager, I think it's really important that in my team, if they've had a lot of stress, then I say, actually, self-care, let me know and I'll get your shift covered. That we use a word that they're not got to go, and it's manager's discretion within the NHS. And peer support networks like the Association of British Paediatric Nurses, all these networks, the Children's Hospital around bereavement networks. When we talk to our peers and colleagues, that's when we get support. We're not just hunkering down and taking all the care on ourselves. So that's self-awareness. I remember what was really helpful for me. There's lots of personality testing out there, but Myers-Briggs, for example. So I just now want to say thank you all for listening. I'm so excited to see what you've all put in the chat box, or any questions that you got. We'll have time to answer some questions. Thank you.
Well, first of all, thank you, Rachel, for sharing a huge amount of experience. I know that we've talked many hours, days, probably weeks, around this subject. And I know there's a lot more to say, but we do have a question in the chat box. It came up, I don't know whether you saw it, when you were talking about the demand for counselling, and we've had a question saying, do we know why there's that increased demand for counselling? You got any views on that?
I have a hypothesis. I'm sure I could be challenged on this one. I do think that with COVID opened up a whole new world, because this is when we saw the demand, where people realised that they needed support and that they were isolated in support. and the impact of death and dying and those existential questions coming in. That's one school of thought. Another school of thought is we're seeing different ages and generations more open up about mental health and finding support. So especially the Generation X. So when I look at my clientele, since I started counselling in 2010, I had very few. I would have about 5 or 10 clients. Now I have a caseload of 30. That is a huge leap from 2010 to where we are now. You know, I delivered 509 sessions last year, and that's what I was saying about that 35% increase. And when I talk to my colleagues and peers around the country, they're all saying, Rachel, there's waiting lists. It's interesting around counselling. People say you shouldn't have counselling in the first 6 months. I have seen no research evidence on that. I'm not sure where that came from, because what we tend to do in that first instance at the time is actually hold families. We don't do very little therapeutic work. We are holding them and listening to the pain, and it's what I call primeval grief. It's really, really raw. And then often 6 months to 3 years later, we decrease the need for the sessions as they enable to allow the world to wrap around them and adapt to their grief.
Thanks, Rachel. There's a question, and it has been answered in the chat box about the availability of slides. The slides will be available, and in addition to the slides, we will actually, at a later date, post the recording of this session, so you will actually get the questions too. Another question was, why does the UK have such a high death rate? Any views on that one?
There are some views on that. So it's quite interesting. I was at the European Grief Conference in Dublin last year, and what was interested in that is that it's collation of data. I think we've been really honest and transparent. Having worked in the 90s in Eastern Europe, they didn't really collate the data. They do now. So I think it is, we are really good at collating the data. We are very open and honest about, I think Europe, you know, France and other countries are roughly the same when we're looking at numbers now around the survival of neonates. And that time of, you know, we've gone down to 22-week survivors, and then they die. It is, you know, that really rocky neonatal period that they go through. So I think we are better at taking care, should I say? I'm a bit political because you can see what stance I'm coming from, what soapbox I'm on, at taking care, and the science is getting better. So we push the boundaries of science to keep children alive, don't we? And which is, I think, is a good thing. When I think about when I started nursing years ago, when I worked in bone marrow transplant, very few, and the oncology wards, very few leukemic children survive, whereas now, when in the 90s, where children are surviving. So we do need that pushing boundaries, don't we, of science?
I think we do. And I think, I mean, just your comment about the care of babies and neonates. You know, that one of the things in Belarus was that they managed to really turn around their mortality rates because they started to ventilate every child, but they never took the children off ventilators. Whereas I think here we actually do try to recognise the best interests of the child. So when we're making those choices, so it may be possible that we would decrease the mortality rates, but when we start looking at morbidity rates, then so I think we've got you know, some different issues there. I'll shut up because I know that we've got more in here in the chat box. So we've got, how can we increase the inclusion of agencies or ancillary staff in the hot and cold debriefs, as they're often missed? I think it's very often it, isn't it? It could be the receptionist, it can be the domestic, who play a very important role in a child's life and a family's life, and then how do we include them?
I did jump a slide because that is a real good part, is in systemic family therapy we look at commemorating. So while we might have hot and cold debriefs, if I'm really honest, as children's nursing, don't always work. The hot debriefs, you're on that shift and you're checking out with each other and you're going home. That works. The cold debriefs, when you're using more reflective cycle, what worked well, what didn't, why. Commemorating is when you have a whole team of you can come round together and you all talk about your experience of that child. It's very, very powerful. I remember talking to a psychologist, a friend of mine who did this, and the parent pleaded, could she come and join in? And they don't normally bring the parents in, and she just wanted to not hear everybody's comments. She just wanted to say to everybody in the room, thank you. You meant and what you meant, and the different ones. She wanted to speak personally at the impact that they had on caring for their child. And then she left. And it was very powerful and a coming together of colleagues, not medicalizing it, but really using that commemoration. So Glenda Friedman is a phenomenal book. She's done death talks, and that'll be in the stack on the slides. You'll be able to use that as a reference point in that commemorating come together. As a children's nurse, and you know, when I fostered children and they died, and myself, I do little rituals, and I think it's finding what fits for you. I often go down to the Thames now if I've not been able to have a debrief, and just peel a flower, petals off a flower, and put them on the river in memory. Just for me, that gives me closure. I'm sure we all have our different rituals.
Thank you. And then a question about setting up a palliative care service, about what you'd consider appropriate or sufficient training for a children's nurse to be able to say they provide a credible bereavement service. Are there any standards that people can find out there?
Yes. So we wrote hospital standards for bereavement, and when a child dies, standards have been written in the UK. Perhaps I could share that with the ABPN and they can just link that through, or how?
Yep.
Or should I put it on the slides?
Maybe if we have it added to the slides, and then they can be, it's sort of an extra on there.
I'll just make a note of that.
All right.
But also you can sign for children's nurses, you can sign up for the Foundation in Palliative Care training at GOSH. That's for everybody. We do that globally.
Okay, thank you. Somebody here saying from Telford, we need more support within neonatal centres for advanced care planning and palliative care during their admission. And certainly we do have people who have got that expertise in neonatal centres, and perhaps I'll pick that up with Fiona, who arranges these sessions, the webinars, and maybe we can look to do something specific for you, Eleanor. I'm just not just for you, but for neonatal nurses. Okay. Donna, you say that you used to have leaflets with signposting to services that you would actually give to people, including domestics, etc. So I think that picks up there, doesn't it? That we've got that. I'm just running down very quickly here. Catherine, thank you. NHS England has published an education pathway for children's palliative and end-of-life care. And there's also the framework that I know that you'll find on the International Children's Palliative Care Network website. I think that's it, that we do have those different resources around, and it is a case of building networks and sharing, you know, regionally, locally, nationally, trying to get that information. Anna has asked whether you recommend any, oops, it's just gone back, I can't see that one, whether you recommend any, sorry, it's really gone back up. So we've got a family support worker asking about recommending any training courses for supporting families with a child who's dying and after death. I think you've mentioned there the GOSH training that's available.
Yeah, so we do when a child dies simulation. It's over 2 days. And we do that bespoke to whatever discipline comes along. they craft that. So Tara Elliott leads on that here at Gosh, and also the Palliative Care Foundation course. That's predominantly for nurses, but the When a Child Dies simulation is open to anybody.
Thank you. And I can see here that Catherine's telling us that the RCN have updated their palliative and end-of-life care competencies. Becky, you've had your hand up for ages, so do you want to come in with your question?
Thank you. For some reason I can't access the chat, so I can't write my question on it. I just wondered if there are any particular courses that would be recommended for children's nurses. So I have a lot of palliative care experience of nursing children, but not so much of the counselling side of things. And I just wondered if there are any courses out there that would be recommended for people in our situation, just to give us that extra edge, I suppose, in supporting families after their child dies.
There's no courses, Becky, I know off the top of my head. I am more than willing to help through that, doing bespoke and helping teams deliver and explore that. So I'm helping different children's hospitals at the moment and exploring the bereavement and the counselling and training. So please get in touch.
Okay, I shall. Thank you very much.
Okay, just a note from Simon to point out another resource, which is the Council for Disabled Children's website about difficult conversations, also Child Bereavement UK. It is a case of, yeah, there's a lot out there, but please do reach out so that we can try to put you in touch. And Vicky, you're asking about training for student nurses. Is there any training that student nurses can access other than that on ELFH? And I think what I would say there, I'm guessing that you're a student, but wherever you are, the other place to reach out to would be your local children's hospices to see what they're able to offer, because sometimes they will offer support in training, and certainly if you're not a student, but you're one of our academics, then again, reach out and we can try to put you in touch with people locally who may be able to help find that training for you. I can see that I've got more new messages to look at. So people saying, sorry, they need to go. Sophia is telling us that Oxford Brookes used to offer the paediatric palliative care course. I think that has now finished. Is it? Yeah, I'm getting nods from Rachel here. So I think that takes us right where. So Helen Dunbar, Together for Short Lives, have just launched their new course, and that's free and online, about learning to communicate with families. So I think especially the comments there about students as well. We've got that. Birmingham University offering a new palliative care module. We've got lots of answers, you see. Robert, I can see you've got your hand up. So.
Yeah, thank you. And apologies for not putting it in the chat. Mine's a question really to the network. I've been doing quite a bit of work. I've just completed a memorandum of understanding concerning the management of child death in hospitals reported to the coroner. And this has now been endorsed by the London Inner South Coroner, Metropolitan Police and Hospitals, which is a valuable document that we use in our local hospitals around South East London. One of the things, though, that my question to the network is the lack of compassion when we have to transfer the child from the A&E department or the ward to the mortuary. We are not able to obviously transfer in our hospitals and local hospitals by the bed, and therefore we have to rely on the undignified trolley that adults are normally transferred in, and obviously it just looks so undignified. My explorations nationally has been that there is nothing available for children, but and those children that are above arm length that can either go into a Moses basket or something. And I just wondered if any other hospital around the country have addressed this issue so that we can transfer children from A to the mortuary with a lot more dignity and compassion than what we currently have to do.
Robert, it's well worth contacting the older centre and Alder Hay Children's Hospital. They are creme de la creme and transferring children. They have lots of different types of trolleys and carry bags as well, which are sealed. And then there's open trolleys, but they have different sizes. So it's well worth contacting Alderhay.
Okay, thank you for that. It's useful signposting. Thank you.
Okay, I'm going to take one last question because we have now gone through. And Robert, if you want to, you'll see that there are some more answers to your question in the chat box. Hopefully you can see that. But Bethan, I think you have the final question of the afternoon.
Afternoon all. It wasn't a question, it was in response to that last question really, and just I can't access the chat box for some reason, for the same reason, so otherwise I would have put the my message in there. We had a similar issue as that previous gentleman. We don't have a specific pizza trolley. We're a DGH down in West Wales, and you know, really we were letting our staff down with regard to the impact of having to transport older children from our ED department, where our prudent process was taking place, particularly those children that were coming in from the community. So actually we've made changes very recently, and it's been really positive, where we transport those children in straight into our mortuary, where there is already set up for that viewing room with a parents' room and a professionals' room to take away that stress for our staff regarding that. And that's worked really well. We've had really good positive feedback of the impact of and the paediatric staff go and help and support the paediatrician in order to do that. And the feedback has been excellent, and the impact on the staff has been really positive. You know, difficult circumstances, but a quiet, calm space. And they've been able to give that family really dedicated time and a really positive experience in that. So even to the point where we facilitated a sibling coming in to say goodbye, which was we would never have managed that in our ED department. So that's been, if I can share that good practice from on our behalf, then and it would help out others.
Did you have help from Shooting Star, from To Wish Upon a Star?
No, not really.
Okay.
No. Obviously,
so
we link
closely.
Welsh, yes, yeah, we link
Welsh
closely with To
organisation,
Wish,
aren't they?
But I think we just recognised that
whether
this
she
wasn't
funded
working.
trolleys and things.
Yeah. So yeah, just to share that. But thank you. That was excellent session. Really enjoyed it.
Thank you.
Got mute, Katrina.
So, yeah. I don't know, it's going on and off at the moment. It's telling me it's time to finish, but I just wanted to say thank you to everyone for sharing your information. And one thing that I would like to say is there's lots of good practice out there, and it's about us sharing it. So please do think about writing things up. Please think about putting abstracts in for conferences. If you're not feeling that you want to write for a journal yet, or you're not really up to presenting at a conference, then have a think about maybe writing something up for the ABPN newsletter. I hope you all get that. It's sort of delivered into your inbox, and it's quite painless. So if you have any questions about how you can do that, then contacting Fiona Smith would be a great idea.